Welcome back to New Directions and Approaches in the Management of Patients with HER2-Altered non-small cell lung cancer. This is medical oncologist Dr. Neil Love. I met with Dr. Joshua Sabari from the NYU Langone Health Perlmutter Cancer Center in New York City to discuss key presentations and publications on one of the most exciting new areas in oncology research, particularly the recent approval of two HER2-directed tyrosine kinase inhibitors, Zongertinib and Sevabertinib. In the first part of this series, Dr. Sabari discussed three cases, and in the next two parts, he reviews a number of key presentations and publications, including perhaps the non-small cell lung cancer paper of the year from the New England Journal of Medicine, Zongertinib in previously treated HER2-mutant non-small cell lung cancer.
John Heymach from MD Anderson presented this at AACR 2025. It was Zongertinib in previously treated HER2-mutant metastatic non-small cell lung cancer. Remember, these are patients that have had prior therapy, so this is not front line here. And what we saw up front was a robust response rate, 71% of patients in response. You also saw a very meaningful progression-free survival here, 12.4 months, and it was well tolerated. So for me, I agree with you, Neil. I think this was one of the first representations of a truly targeted agent in the HER2 space. This was practice changing. This study led to an accelerated FDA approval in the second line setting. Obviously, there is a confirmatory phase 3 study ongoing right now. When this data came out, I really saw a huge transition in patients, or in clinicians' focus on how to treat this mutation. A lot of patients are already getting, or were already getting, trastuzumab deruxtecan in clinical setting in the second line. What do you then do with that patient? Well, we looked at that patient population as well, and we saw response rates north of 40%. So even in patients who've had prior chemo and immunotherapy, prior trastuzumab deruxtecan, we still were able to achieve about a 40% response rate in this patient population. So, the data was very exciting. I will mention one group of patients where we didn't see robust activity. I think we mentioned this is in the non-tyrosine kinase domain mutations. Those are mutations that exist outside of exon 18 to 24. Remember, the most common mutation is that YVMA, exon 20 insertion, really robust responses on Zongertinib. But for those mutations that exist outside of the tyrosine kinase domain, we saw very low response rates at about 30%. So the approval right now is in activating tyrosine kinase domain mutations.
Although, 30% is not an insignificant response rate, so I wonder if at some point with more data, we'll even go beyond that. But maybe you could talk a little bit about tolerability. Again, the other TKIs we use in non-small cell lung cancer are generally very well tolerated, but, they're not like taking Tylenol. They do have problems associated with it. You've one of the few people who've actually had experience with this agent. Can you talk about what this study reported and how that syncs up with your own experience?
Yeah, so anytime I look at a new targeted therapy, I want to understand, how well is it tolerated, and, how are clinicians utilizing it? Do they need to dose reduce? Do they need to discontinue therapy in the setting of toxicity? Well, what was really striking with this agent is the rate of discontinuation was quite low, 3% of patients. So most patients did not need to discontinue therapy. The rate of dose reduction was 7%. So, this is a very well-tolerated therapy. What are the side effects? We can see some slight rash or redness in the skin that occurs for the first 1 or 2 weeks and then improves. We don't see true acneiform rash like we see with other, EGFR-directed therapies. We can also see mild diarrhea, mostly grade 1 and 2. The rates of grade 3 diarrhea in this population was low at about 1%. You can see AST and ALT elevations, and therefore I do recommend monitoring the AST and ALT every 2 weeks for the first 3 months on therapy. And the reason that being is if patients have mild elevations, you may hold or reduce the dose to prevent them from having that grade 3. Grade 3 requires a dose reduction with this therapy. So overall, it's a very well-tolerated medicine. I'd put it in the same category of osimertinib, for example, or alectinib in the ALK space.
So actually, I was just thinking to myself, so this drug got approved without a randomized study.
That's right. It got approved based on a single-arm study in a high unmet need patient population. And, kudos to the FDA for being aggressive here and being mindful to patients in need. I always tell my residents, my fellows, patients are waiting. While we're studying medicines, patients are waiting. We're losing people. So the fact that this drug had such a high response rate, such good durability, we got this approved in the second-line setting. And, more recently now in the front-line setting as well. So it is a practice changer for me in my clinic.
Yeah, so we're going to get into the first line. That's even more exciting. Actually, let's get into that. This is a presentation from ESMO of the Beamion LUNG-1 study, HER2-mutant disease, Zongertinib as first-line treatment. This is like a shocker to me. I mean, not really, but kind of amazing in a way.
So again, this was a single-arm study as part of the Beamion LUNG-1 study where we looked at patients who were treatment naive, so frontline patients treated now with Zongertinib. And what we wanted to understand was the objective response rate and the PFS. And again, patients were dosed at the 120 milligrams daily. We are looking at other dose levels now as well in clinical trial practice. But I agree with you. Sanjay Popat from the Royal Marsden presented this at ESMO 2025. We saw response rates of 77%. I mean, this is quite impressive, Neil. And if you look at CRs, complete responses, 8% of patients achieve complete response. So these are deep responses that we're seeing in the frontline setting. And if you look at disease control rate, right, which includes stable disease, we're at 96%. You don't see numbers like this for chemo IO. You don't see numbers like this for ADCs. These are truly targeted therapy numbers. We also saw impressive durability in the frontline setting, and based on a sort of accelerated approval, a voucher that was awarded to this company, this drug then got an approval in the frontline setting. Neil, I don't know of any other drugs that have frontline approvals without having a randomized phase 3. So this data was so impressive that the FDA granted this a full approval. Again, this will be hopefully confirmed on the randomized phase 3 study. We didn't see any additional toxicity signal in the frontline setting patient population. Similar rates of, GI toxicity, diarrhea. We saw similar rates of, skin issues, rash, redness. Again, mostly the first 1 or 2 weeks, mostly grade 1. And we saw similar rates of AST, ALT elevation. So really no new side effects were elucidated with this agent. A lot of people ask me about ILD, interstitial lung disease, especially in patients who may go on to receive chemo IO or other agents. It was very low. There were single-digit rates of ILD, I think about 2% or 1% in this patient population. So for me, the frontline data really confirmed, recapitulated what we saw in the second-line setting.
So actually, hearing this story kind of reminds me of what happened with EGFR. There was a very famous study that I'm blocking on the name. I'm sure you'll remember. We were talking about it all the time, where they randomized between upfront chemo, and I think it might have been gefitinib. Tony Mock, I think, was the PI on that. And of course, even gefitinib blew away chemotherapy. And then we started to see ALK. And I'm not sure exactly how many randomized trials have been done in the first-line setting with targetable mutations, but a lot of targetable mutations are now getting treated in the first-line setting. And kind of what I saw evolve was after we had a couple randomized studies where we saw such a difference, then what people were saying, well, if there's a response rate of 40, 50, 60% first line, we don't need a randomized study. We already saw it in this other study. And kind of that's what happened here, I think.
Yeah, and that's the IPASS trial. I agree with you. That was a revolutionary study to replace chemo in the frontline setting. I think the problem there, Neil, is that with immunotherapy approved in combination with chemo in the front line, you still are seeing some durable responses in patients. And, so it's hard to replace that. And I think the randomized phase 3 studies, would I love to be on the control arm of one of those trials getting chemo IO? No. But I think we need that data to be sure and to understand that the durability is there, that the overall survival is there. Clearly, we see that the response rate is much, much higher than what we're we're achieving with chemotherapy and immunotherapy. And Neil, just to give you context, historically in my own practice, what I see for duration of response for chemo and immunotherapy in the frontline setting is median 8 to 9 months. Now, I have patients that are far out that have done quite well. So I think we need to tease that out in a randomized phase 3 study.
Yeah, that's a great point there. So, yeah, I guess in terms of first-line therapy right now, what are the targeted therapies that you use in the first-line setting in your practice for non-small cell?
Well, I think for, different mutations like EGFR, I'm standardly using, there are 3 regimens now, osimertinib plus chemo, as well as amivantamab plus lazertinib. Those are the 3 FDA approvals in the frontline setting. For ALK fusion, we saw it beat out chemo as well. There are many next-generation ALK inhibitors, alectinib, lorlatinib, brigatinib, and, in the ROS1 space, many agents, taltrectinib, repotrectinib, and now HER2 is added to that space, right, where we now have a TKI in the frontline setting with Zongertinib. I think it's natural to think about this patient population differently than we think of the driver mutation negative patients. And remember, this is the first TKI to be approved in this space, in the HER2 space. For my patients, I hope that in the coming years we have many other iterations and improvements upon this, as well as combinations similar to what we've seen develop in the EGFR space. Neil, we're looking at 4-year median overall survival in EGFR space. We're nowhere near that in the HER2 space. This is the first step, I think, in the right direction.
So, it's kind of ironic, too, after having this IPASS study and saying, we can just go with better tolerated targeted therapy. Eventually, we ended up adding the 2 together, but we'll see whether that actually happens here. What about the phenotype? That was another thing that struck me when I first talked to Dr. Heymach, that this idea of the non-smoker, the woman, I don't know if you see it more in Asian, but how strong is that phenotype correlated with these mutations?
So for driver mutations, we always do think of that younger patient, that patient who never smoked. We more commonly see it in Asian patients than non-Asian, right, Caucasian. But HER2 is different, right? HER2 mutations are seen equally across smokers and never smokers. If you look at some of the more recent studies, it's actually a 50-50 breakdown. We also see it in men and in women, right? So it's not only a disease of women, and we see it in Caucasian as well as Asian patients. So, the point that I would make here is that you should not judge a book by its cover. You should not say, in a young Asian patient, I'm going to get NGS. You should get NGS in every single one of your patients, because we can't predict who's going to have what mutation up front. So it's critical that we test all patients in this setting.
All right, let's go on to this next paper, another New England Journal paper, another great breakthrough in terms of TKI, but now Sevabertinib. Can you talk about what was looked at in this study, what they saw, and how it sort of indirectly compares to what we've seen with Zongertinib?
Yeah, so again, a lot of excitement in the HER2 space. 2 New England Journal papers back-to-back in this setting. Sevabertinib is a HER2 and EGFR inhibitor, so it's not selective for HER2. And it's an interesting compound that has potential broad activity in HER2 mutation. So Engl at MD Anderson presented this data at ASCO 2025. And we also saw quite impressive data for patients who were, active or second-line therapy patients, response rates north of 60% in this patient population. We also saw cohorts of patients who had previous HER2-directed therapy, and the response rates were quite impressive. Now, for me, the differentiation between this agent and Zongertinib, which is HER2 selective, is in the toxicity profile. So when we saw this data presented and published, we did see high rates of GI toxicity. So diarrhea, Neil, occurs about 84%, about 20+% being grade 3. So that's 6 to 7 loose bowel movements a day. We also saw increased rash because of EGFR inhibition, about 50% of all patients, 9% or so being grade 3. And then we also saw some of the other EGFR-mediated side effects, paronychia, stomatitis. We did not see any increase, hematologic toxicity. There really was no signal here for ILD, and we did see minor AST and ALT elevation. So I think historically, this would have been an amazing therapy, in my opinion, right? Because it had high response rates, great durability. Yeah, we got to deal with the EGFR and HER2 side effects. I think in the era, though, of Zongertinib, where we are selectively hitting HER2, I'm not sure I would use Sevabertinib in the second-line setting at this moment. One interesting thing to note, and it was published in the Cancer Discovery paper, is that there are some resistance mutations to Zongertinib, particularly 805S. So patients who are treated with Zongertinib that develop acquired resistance may have activity with this drug, Sevabertinib. So we don't have any clinical data yet, but we have preclinical data. And I think sequencing, similar to what we've seen in EGFR, repeating NGS, both with plasma and tissue, will be very important, Neil, for us to understand how to better sequence these therapies in our clinical practice. But for the data we have right now, Zongertinib looks to be slightly better in the efficacy standpoint and definitely better in the safety profile. So I would use Zongertinib over Sevabertinib at the moment. But really exciting to see another agent. Why is this important? Look, if one patient's not able to tolerate one agent, it's great to have another agent there available for our patients.
So kind of just flashing on CDK inhibitors in breast cancer, when you're talking about diarrhea, and one of them, abemaciclib, is associated with diarrhea. They've been kind of working on that to try to figure out how to minimize that, but there are a couple others available, less toxicity. But then they came out with a trial where it was combined with a SERD that hadn't been done with the other CDK inhibitors. They used it in the adjuvant setting in a trial which hadn't been done. Both of those trials were positive. People use it and they just deal with the diarrhea. So I wonder, even though right now it looks like you're comparing monotherapy, you never know what the next trial is going to come out. It'll be positive. Usually people use the drug, although sometimes that changes. So we'll see how that evolves in terms of these really exciting TKIs. This concludes part 2 of our series. Special thanks to Dr. Sabari, and thank you for tuning in. This is Dr. Neil Love for new directions and approaches in the management of patients with HER2-altered non-small cell lung cancer.